The next procedure is something that occurs not uncommonly in patients that have complicated pneumonia and respiratory distress, and their pleural cavities have either fluid collections or empyema with sepsis. And we are called not infrequently in the urgent situation to relieve this fluid collection to support the resolution of the respiratory distress and remittent fevers. Here we have the reality that sonography gives us a key advantage in evaluating these empyema cavities and the changes in the fluid over time, and it allows us to prognosticate for fibrinolytic therapy. For fibrinolytic therapy dosing, 2 milligrams of TPA is our standard dose, given in 20 milliliters of saline and allowed to maintain its dwell time for 1 hour. If we do this every 12 hours, we usually will have success within the first 1 or 2 doses, and 2 or 3 days of this regimen will usually clear even the largest of the empyema cavities. This regimen in our practice has given us greater than 95% success in treatment of empyemas, and essentially less than 5% of our patients ever go to surgery. This works when we have favorable fibrinous or fluid dynamics, and we will go through this sonographically in the following slides. And again, sonography allows us to evaluate in a prospective fashion. It allows us to prognosticate very clearly to determine whether the pleural fluid can be drained effectively with or without fibrinolytic therapy, and whether the empyema can be treated non-surgically. Grade 1 allows us, without any fibrinous collections, to put a chest tube in and drain that collection immediately and completely. At the time of drainage, we will leave a drain in place for 24 hours or 48 hours until drainage stops. Grade 2 empyemas with early fibrinous change and early organization, we can put a chest tube in, institute TPA, and we will usually resolve the empyema fully with this chest tube and TPA therapy. Grade 3 empyemas that are heavily organized, we will give a trial of fibrinolytic therapy. However, usually these patients, if required, will need surgery to clear that solidified and heavily organized collection. Here we see a young child with left lower lobe pneumonia and a large empyema cavity. Here on the CT, we see the empyema, but the CT does not help us characterize this empyema for prognostication purposes. Here we see on the ultrasound, the arrow is on the non-organized parapneumonic effusion, and again, in the absence of fibrinous organization, this fluid collection can be drained completely at the time of chest tube placement. Here we have the needle with ultrasound guidance placed in the pleural fluid collection, and this arrow is on the pleural surface of the lung as it reinflates, and we can see that the parapneumonic effusion is completely drained. Here we have another case, similar situation, similar CT appearance. Now the ultrasound shows us that this is beginning to organize in a grade 2 organization fashion, fibrinous organization, but the arrows now are on the dark fluid locules that tell us that the TPA will indeed work and successfully resolve this organizing fibrinous empyema. Chest tube is in place. This is the CT scan following 4 days of fibrinolytic therapy, and we can see that there is no evidence of any residual pleural component. Even in cases where we may have small residual organized empyemas, this small amount of organization will be densely organized. There won't be any free fluid, and if we look sonographically, we won't see anything that's drainable. Antibiotics will penetrate this successfully, and we can remove the chest tube and have greater than 95% resolution of the empyema cavity as an excellent result. Here we have a patient that was in severe respiratory distress with a tension hydrothorax and empyema cavity, and you can see displacement of the mediastinal and cardiac structures to the left. Sonographically, we see this as a grade 2 empyema with fluid-filled cavities and fibrinous organization. We know by looking at this that fibrinolytic therapy will be successful. So at this point, with sonographic guidance, we'll place our needle through the sheath. We'll then place a wire and a coaxial 4 or 5 French U, and that's the name of the catheter, YUEH. The 4 or 5 French U needle and sheath system provides us great single puncture access. the needle removed, and then through the sheath we can put a guide wire, then proceed with fluoroscopically guided placement of dilators and the catheter. Catheter is in place, TPA for a few days, and once drainage stops, then we can see that approximately 1 month later, the empyema is essentially cleared with a small amount of residual pleural thickening. The patient is afebrile and no longer requires oxygenation. These two images demonstrate the two phases, grade 2 to grade 3. And again, as we mentioned, the grade 2 image on the left will be responsive to fibrinolytic therapy with greater than 95% success. And grade 3 on the right is going to likely require surgical management. We will still put a chest tube in there and try through the pigtail catheter to have success with fibrinolytic therapy, but greater than 50% of the time that is not successful. Now, in some situations, we are requested by the cardiologist to support the patient with emergent pericardiocentesis when either the patient is very small or the effusion is in a situation where they request our help with sonographic placement. Here we have a young child with congenital heart disease and is having difficulty with respiratory distress and cardiac output due to a large effusion. Here we see the arrow on this pericardial effusion, and with an animation in a cine clip we see the changes in the pericardial effusion with motion of this small child, and so we were asked to support the patient with placement of the drainage catheter. Here we see with the curved arrow the needle is in place, approaching the pericardial surface, and we're administering lidocaine for local anesthesia in this patient that was under deep sedation for this procedure. Next we see the needle in place, and this is the vascular sheath. In this situation, this is a 14-gauge Angie catheter that is in place in the right pericardial recess. And we can see that the needle has been removed. We have the plastic sheath in place, and the arrow is on the tip of this vascular sheath with no cutting surface to injure the patient. A few slides, and we will go through this in greater detail when we discuss small abscess drainage. But this is the 14-gauge Angie catheter, and we'll illustrate how we gain access to the pericardial effusions with a coaxial technique, beginning with the 14-gauge Angie catheter. So the Angie catheter is then placed into the pericardial effusion. Once it's accessed, the sharp needle is removed. Then in a coaxial fashion, a 5 French pigtail catheter without any stiffening wires or trocars is then advanced in a coaxial fashion, exiting with the soft tip of the catheter. It then curls as it exits through this 14-gauge Angie catheter sheath, and you can see with the 5 French catheter in place and with a cine loop we see the catheter coming from the skin surface into the pericardial effusion and clearly missing the right atrial margin. Once that catheter, again with no sharp instrumentation, it can be advanced fully into the pericardial recess, then repositioned into a good inferior position and secured to the chest wall for drainage. This child drained 75 cc's of pericardial fluid over a 3-day period, and then it was removed and the child was sent home.